And I think this echoes the importance of these consensus statements that we've been working on, that have gone through 15 revisions with over 15 different doctors, clinicians, and scientists. We need consensus statements to rely on. And with that, I think I want to invite our first speaker, somebody who I should also thank, who has participated in these guidelines, and a lot of her seminal work has actually gone into that consensus statement we've worked on. Her edits have helped us elevate those guidelines. I want to welcome and introduce Beth McNally. Beth McNally completed her Master's of Science in Nutrition and Integrative Health. She became a certified nutrition specialist. She works very closely with Miriam Killiam from our board, if you guys don't know. And I think she, not only does she bring unique perspectives as somebody, an expert in the field, she also brings expertise as a parent with a son with type 1. Beth McNally's journey with nutrition began in 2015 when her son was diagnosed with type 1. And starting from those first questions that those parents often face, like what should they eat, what is type 1, what is a carb, and now here she is coming on our stage as an expert speaker and as somebody who's helped elevate that consensus statement that we'll be publishing very soon. So thank you, Beth, for joining us.
Thank you, Joe. Thank you. Okay, good afternoon, everyone. I must say it is wonderful to be in a room with so many people who care about type 1 diabetes. And I also want to say a warm welcome to everyone who's watching online as well, because I know a lot of you wanted to come and be in person today, but that's not always accessible to everybody, so you're watching online, so welcome. So I'm here to talk about implementing therapeutic carbohydrate reduction, TCR for short, for type 1 diabetes. And before I do that, I'd like to tell you how I ended up in this intersection between caregiver and practitioner. So I've got one foot in each world in type 1 diabetes, not as someone who has type 1 diabetes myself, but as a mom. So as a caregiver to my now 17-year-old son who has type 1 diabetes, and he navigates diabetes daily, and also as a clinical nutritionist now. There we go. So when my son Lachlan was diagnosed with T1D at the age of 9, about a month after he was diagnosed, we found out about Dr. Richard Bernstein's Diabetes Solution book. And with guidance and support from Lach's wonderful diabetes care team at our local children's hospital, we started to implement Dr. Bernstein's protocol, and our whole family adopted a TCR way of eating. And with time and practice, serving TCR meals like this became a relatively straightforward approach. Lachlan's blood glucose sugars, as soon as he started this diet, changed dramatically. And I have to tell you, putting myself back in that time, I remember his grade 4 teacher saying, okay, so you're getting him on this new diet, you don't want him to have any candy at school, how long will this diet go for? And I said, I have no idea, but we can't do this very long. It seems a little different. And then I saw that. That was the first part of the graph, is when he was eating high carb for 2 months. And on day 1 of taking out foods that spiked his blood glucose levels, we suddenly had him in normal range. And I remember sort of my stomach, like I got a gut punch as a mom, and I went, oh, okay, I've got a good thing here, because I could never have imagined the results could be this different. But then I also went, okay, we really have to go all in on this. So our goal was to normalize blood glucose levels, and that helped to solve that problem. But I still did have a bunch of burning questions. It's 2015, there's not a lot of information available. I'm really worried if he's going to grow. Like, is he going to grow okay? Is what we're doing fine? And if so, like, why aren't the doctors telling us to do this? Right? It's just not going through. There we go. So I'm pleased to report that 8 years later, that 9-year-old boy has grown into a strong young man. So he now manages his health well, and he has also, on this low-carb diet, been able to reach a high level of athletics. So last year he qualified for the Canadian Olympic swim trials, and he follows TCR, and he eats 30 grams of net carbs a day, plus enough protein and energy to meet his growth enough protein and fat to meet his growth and energy needs. So I personally find TCR effective because it helps my son. However, as a clinician, I recognize that each individual's needs and preferences vary. So I support people, in a non-judgmental way. They have choice in what to do. But I do think it's really important that people with type 1 diabetes are offered this option and made aware that there is this possibility. So to start off with, today we're just going to dive right in. I can't talk about everything that I want to in the short time that I have, but I'd like to first start with why TCR makes sense for type 1 diabetes. Then we're going to look briefly at what the impact of macronutrients are on blood sugar levels and insulin needs. And then finally, because I know a lot of dietitians and nutritionists are looking for guidance on how to support people, we're actually going to look at the nutrition care process, and we're going to look at nutrition assessment and nutrition implementation so that you can support patients in your own practices. So let's start off looking what happens when type 1 diabetes occurs. As we know, the body cannot naturally secrete the hormone insulin, so this results in metabolic dysfunction. So now we can't balance blood glucose levels, but the body also can't utilize its fuels. And this is why I don't understand why we don't connect the nutrition problem. In type 1 diabetes, we can't actually metabolize carbohydrates, fats, and protein. So it creates a really unique nutrition problem. So insulin therapy is available as the medical treatment. And the goals of type 1 diabetes management, as we know, is to ensure that we keep the blood glucose levels as close to normal as possible without severe hypoglycemia or hyperglycemia, because we want to maintain the health of the blood vessels, organs, and avoid diabetic complications. And we're not talking here about the diabetes organization's blood glucose targets. We're talking about normal, non-diabetic blood glucose levels, because we need to be able to avoid the damage from hyperglycemia. So just as TCR can be used as a nutrition therapy for a variety of conditions, TCR for type 1 diabetes offers the potential to stabilize blood glucose levels, decrease insulin requirements, and cultivate a sense of empowerment and self-confidence in managing the condition effectively. So how is this possible? Why does TCR make sense for type 1 diabetes? And to answer this question, we're going to look at four questions. Number one, what's the problem in type 1 diabetes? Number two, what opportunity is available to help provide a solution? Number three, what practical steps can we take to get to the solution? And then finally, what will the outcome be? And the content that I'm presenting here is not that new. We've known this for decades, particularly thanks to Dr. Richard Bernstein, who has been providing this content to us for decades. And I think it's very important that we pay attention to it if we want to be able to help people with type 1 diabetes. So let's look at the problem. Patients are presenting with fluctuating blood glucose levels, which increase the risk for diabetic complications. And obviously, it's because the body can't produce insulin. But what contributes to the problem of fluctuating blood glucose levels may not seem obvious to everybody. A lot of people think that as soon as you get the insulin therapy and you start injecting it, you should be able to replicate what the body does naturally. But that's just not the case, and some people might not realize why. Why is it so hard that only 17% of adolescents and children and only 21% of adults in the US can meet the ADA's targets of 7.5 and 7.0% for A1C levels? So the variability of exogenous insulin and of blood glucose are major contributors. And while insulin is a life-saving medication, it cannot replicate what the body does naturally. So we have variability of action in exogenous insulin, both in its absorption, where are we injecting it, how much fat is in that area, how many times have we already been injecting the insulin into that same place over and over, and also we have variability because of the effects of insulin as a medication. So there can even be effects where The same person is getting the same dose of insulin, and we can have variability from the medication from 15 to 35%, which one study revealed. So that's what people are dealing with on a daily basis. And finally, we have an opportunity, because we know that many things affect blood glucose levels, but the thing that affects blood glucose levels the most is the food that you eat, and we have to eat food every day. We don't have this choice. So the opportunity is to be able to choose foods that result in smaller glucose excursions, and also that will lead to smaller doses of mealtime insulin. And this is where we can refer to Dr. Bernstein's laws of small numbers. To ease the workload on the body, we consider the inputs that impact the blood glucose swings and the insulin variability. So with fewer swings in insulin levels, there's less room for mistakes in timing or dosing, and this reduced pressure on the system contributes to a more stable and physiological balance. So we implement TCR, a TCR nutrition plan. And the one thing that we have to be really careful about here is that insulin doses need to be adjusted. So many of us know this who are in the room, but this is really important because I hear a lot of the times, well, we can't do therapeutic carbohydrate reduction for type 1 diabetes because the risk of hypoglycemia is greater. And you can ask anyone in the room who lives with type 1 diabetes, what causes hypoglycemia? Too much insulin. So if we make sure that we have the right amounts of insulin and the right types of insulin, then we can help reduce the chance of hypoglycemia regardless of the food that you're eating. But when you actually use TCR to be able to do that, you're using smaller doses of insulin already. So even when you have a hypoglycemic moment, you often have what is sometimes referred to as milder hypoglycemia. You don't have a quick drop from a rapid-acting insulin. You have a slower, milder hypoglycemia, which is easier to treat. So finally, what are the outcomes? So we have some studies that tell us, and Dr. Boudreau mentioned some of them in her last presentation, we see a reduction in a lot of things. And we actually really like to see a reduction in this area. A reduction in post-meal blood glucose rise, a reduction in insulin doses, reduction in variability of insulin absorption and effects, and a reduced risk of hypoglycemia. And that all leads to a reduced risk of diabetic complications. But it also has effects on quality of life. And I think this is where the challenge is, because if you see the way I have tried to describe what we're talking about in terms of problem, opportunity, practical steps, and outcomes, you can sort of see that on the bottom, when we see the problem and the practical steps, those are sort of negative things. Those are challenges, those are hard things. So obviously the problem is hard, but then also the practical steps can feel hard to people. You know, how do I do this? I have to change, I have to make changes, I have to change my habits, I don't really know if I'm going to be able to do it. And I really think that we have to empower people, and we have to make them feel that this is possible, and we have to surround them with other people that are having success so that they too feel like they can do this. Because what's waiting for them at the top are the outcomes, and what's really difficult to explain, because I've even had doctors say to me, well, your family is different. Right? Like, you guys are pretty smart and you were able to figure it out. And I say, yes, but it's just food. And if you could change the food, what you don't understand is everything else got easier. We stopped having to take Lachlan off the hockey rink when he was playing all the time because he wouldn't go low as easily. He didn't have to sit out at birthday parties, or we didn't have to prevent him from doing things. So quality of life, got a lot, really changed for our family, and I know it has for a lot of other families too. So let's move on and look at the impact of macronutrients on blood glucose and insulin needs. And I'm going to try to be brief here because I really want to get to the implementation side of things. So just a reminder that the building blocks of carbohydrate, protein, and fat are glucose, amino acids, and fatty acids and glycerol. Now for carbohydrate, obviously we have simple sugars, and we have 3 of them, but the most abundant one is glucose. So I've abbreviated this, but what you're looking at here are the top 2 charts. Basically, we have dietary carbohydrate, where people that do not have type 1 diabetes, non-diabetic people, were provided with 50 grams of dextrose. And obviously, that's straight sugar, So that's not the typical thing that we would eat on a daily basis. But what I'm trying to show here is that the glucose response is quite significant. And then the insulin response in the next chart is also quite significant. And when people that do not have type 1 diabetes eat dietary protein, you will actually see in the bottom left corner that you don't actually see much of a blood glucose response. But what a lot of people don't realize is the very last chart in the very bottom right is there actually is an insulin response from eating dietary protein, even in those people that do not have diabetes. It's just that the body works so that you really don't see the response from that. And this is really important to understand because so many people in the type 1 diabetes community, when they ask for support in getting help with insulin dosing for their dietary protein intake, are told, oh, no, protein doesn't affect blood sugars. Don't worry, you don't have to cover that. But clearly they're seeing on their CGMs and from their glucometers, they're like, well, I guess I'm a very individual, unique person then because I'm having high blood glucose levels. So it's very important to be aware that dietary protein does have an impact. However, you can see that the impact of the dietary carbohydrate is rapid and immediate and significant, and you'll actually notice that the insulin response for dietary protein is not as great. So what we can do in order to reduce that swing in carbohydrate is we just sort of move. We still want to eat carbohydrate foods unless we decide to follow a carnivore diet. We go to carbohydrate foods, but we just sort of select them from the right-hand side of this visual, and that allows us to avoid rapid blood glucose spikes when eating. A lot of people are concerned about the nutrient density of therapeutic carbohydrate reduction, so we also need to make sure that we remind them that we're getting lots of good sources of vitamins and minerals in the carbohydrate foods that we're choosing when we use TCR. So back to our effects on blood glucose, this is now a study in people with type 1 diabetes. So for people with type 1 diabetes, protein can have an effect. It's not a direct effect, as in protein does not break down into glucose molecules when they hit the bloodstream. I think that's very important for people to know because they often think that that's the case, and that's actually not the case. And we don't see blood glucose levels rise immediately after eating, as I mentioned, because it actually takes some time. And what happens when you consume dietary protein is both insulin and glucagon are released when dietary protein is consumed. But in type 1 diabetes, because we don't have a natural secretion of insulin, we need to be able to dose to cover that need. So we'll see a slow, gradual rise. Often in studies, we'll see it at about the 90 to 100 minute mark. I would like to tell you exactly how to approach this if you are a person with type 1 diabetes or a practitioner. And I think this is where it feels complicated to people. All different proteins react differently in the body. So I'll just give you an example, within my own family. We need much smaller doses when Lachlan is having something like a fish versus when he's having something like a red meat. So a red meat will actually have a much longer blood glucose response than something like fish would. And it also really just sort of depends on what he's eating. And if we went around the room and asked everyone with type 1 diabetes today, okay, how do you dose for protein? We'd probably have 15 different sort of variations of what we do. So we have to make sure that when people are looking at how they're going to deal with dietary protein, that whatever they're doing, they actually are tracking everything. And you figure out what works and what doesn't, and then you go to the next time you eat that meal and you try again. So just really briefly on dietary fat. Again, dietary fat's effects do have an indirect effect. Fat may delay the rate of stomach emptying, so the carbohydrate in the meal may be digested more slowly, and you might then see a blood glucose rise occur later, hours after eating the meal. And a high-fat meal can also increase insulin resistance and lead to postprandial hyperglycemia. This is another really interesting one for me. So I sort of wear two hats as a clinician. I work in the type 1 diabetes world, but I also work on Miriam Kalamian's Keto for Cancer nutrition team. And we actually use fiber and fat to delay the glucose response for our clients who are in active cancer treatment. And it's because we want that glucose response to be delayed. So that's how we use it in that way. But we also have to be really careful if we eat a high-fat meal, and people always want me to define that. I'm like, well, in the dietetics world, people say 25 grams or more, but sometimes I can feed my son 75 grams of fat, and we don't really see a huge release. He's got that covered with his regular insulin. So it really just depends on also what type of fat you were eating and how it sort of works in combination with the meal. But certainly fat does have an effect on blood glucose levels. So getting to this next section, Therapeutic Carbohydrate Reduction Nutrition Assessment and Intervention. The reason that I want to cover this in this way is I really want to help dietitians and nutritionists who want to support people who come to them and they have type 1 diabetes and they want to do TCR. And a lot of people have said, I don't know how to help people. I don't know where to start. I'm not sure if this is safe. And I think we need to start providing more information so that people feel like they are able to support people. So the nutrition care process is the process that we use as dietitians and nutritionists to evaluate an individual's nutritional status. And there are a number of steps in the process, and they include nutrition assessment, diagnosis, we figure out what the nutrition problem is, nutrition intervention, and then monitoring and evaluation. So today we're going to talk about nutrition assessment and nutrition intervention, and I'm actually going to ask for us to have a little bit of dialogue or conversation as a group. So just a reminder, I know a lot of people in this room know what therapeutic carbohydrate reduction is, but I just sort of want to review this. Very low carbohydrate, 50 grams of carbohydrate or less, and low carbohydrate is anything from less than 130 grams per day. One quick thing I want to say before we get into the nutritionist assessment steps. I have a lot of people who are really concerned, particularly when children adopt this way of eating. And as a mom, wearing my mom hat, I was like, wow, really? Like we're serving our children whole foods? I don't really understand this. And then I got into my graduate studies, and the plate on the right is, a classic keto 3-to-1 ratio diet. So when you go through your studies in your dietetics and nutrition world, I'm like, oh, everybody thinks my son is having olive oil and a little bit of broccoli and some heavy cream and this tiny portion of salmon. That's what they think Lachlan eats on a daily basis. And I was like, no. It's for the children, we're often looking at a low-carb, high-protein approach, and it's the meal on the left, which I think a lot of people can recognize as looking like a fairly normal meal. So I just want to be careful because I struggle when people use the word ketogenic diet in relation to type 1 diabetes, simply because when you are in the dietetics field, it really is, this is to treat epilepsy, and it's to stop children's seizures, and it really stunts growth. So we really need to move away from that, and that's why I love the term that Adele Haidt brought in. I think her views on how to use language are so important, and therapeutic carbohydrate reduction is a way to look at all of these different options that I have in the circle here, where if you want to be a vegetarian and do TCR, you can. If you want to eat a ketogenic way of eating, you can. If you want to do low carb, high fat, or low carb, high protein, it's all encompassed within the TCR realm. Okay, so nutrition plan for people living with type 1 diabetes. I sort of like to explain this in a really simple way. We're having adequate protein, adequate healthy fats, and we're having carbohydrate foods that won't spike blood glucose, and obviously we're hydrating. And the goal is to support blood glucose stability and also to ensure that we're obtaining the essential nutrients that we need for human health in general. Vitamins, minerals, essential amino acids, essential fatty acids. We have to be really specific in type 1 diabetes because we have to make sure that our foods are sort of planned throughout the day. So this is just one example of how you might want to think about being able to break this down using the different very low carbohydrate, or reduced carbohydrate types of approaches. So now on to nutrition assessment. I also do want to mention I have many handouts at the very end of my presentation, which will be shared with you so that you can actually have some of the pamphlets to use as well. So there's no need to worry about writing everything down. You will receive everything. Okay, so I think it's a lot more fun to do this as a mock clinical scenario. So we are going to say that we have a person with type 1 diabetes. Their name is Jordan. They've been diagnosed with type 1 diabetes. We don't really know when. They could be any gender. They could be any age. And they've come to you requesting support to implement TCR to help them manage their diabetes. So I'll get us started on the screening stage. So screening is one of the components of the nutrition assessment stage for a dietitian or nutritionist when they first start working with someone who has come to them looking for help. This also, I have done this as if you are a dietitian and nutritionist, and you are going to be collaboratively working with the medical professional who is prescribing the insulin. Okay, so we are in our nutrition lane right now. We are in our dietetics lane, and I have not assumed that this person has a certified diabetes educator credential. This is just from a dietetics and nutrition perspective. So the first thing that you always do when you see anybody is you do an initial screening for malnutrition. Particularly in type 1 diabetes, we want to consider unintended or unexplained weight loss because we want to understand why that is happening, particularly because we think about things like, could this person also have celiac disease? Could this person also have thyroid dysfunction that needs to be evaluated? So we think about those kinds of things. We also look at a recent DKA event because we want to ensure a few things. One, that the person is being medically monitored as they, after they've just come out of that. We also want to make sure that we understand why the person went into DKA. Is it a first diagnosis, they've just been diagnosed, or is it possible that they have gone in and out of DKA many times, and we need to make sure that they have the support they need to try to have that not happen again. The second point, and we do this for everybody who comes, regardless of what they're coming to us for, monitoring for an active eating disorder or a history of an eating disorder. If somebody, through the screening process, shows sign of an active eating disorder, we would not proceed with TCR. We would not proceed with almost any dietary intervention. We refer immediately to specialists who are specialized in eating disorders. If someone has a history of an eating disorder, they may be a candidate for TCR, but we need to make sure that we dig in and understand their history, who they are working with so they continue to get support on that side of things, and then also you figure out your place in how to coordinate that care and how you can support that person. So there are new research studies coming out about the use of the ketogenic diet for helping people with various eating disorders. I'm looking forward to seeing that. I'm looking forward to seeing further research in this area. So I don't want people to think that if someone has a history of an eating disorder, they automatically should not even be considered for TCR, but it's something we need to be aware of. Contraindications for TCR, very similar to what you would find with TCR complications across the board. One thing we really need to make sure is patients must stop taking SGLT2 inhibitors. And so I also have multiple pages listing all of the contraindications after this. And finally, warrants close medical supervision. So when I'm seeing Jordan, I want to make sure that I'm being careful of the list that you see here, history of renal stones or gout, etc., because we want to make sure that there's close medical supervision. It does not mean that Jordan cannot commence a TCR diet, but I do want to be very aware if there are any additional needs that Jordan has that may require further coordination of care. So these are just the contraindications that are listed in more detail, which will hopefully help clinicians to look at that. So finally, as part of the nutrition assessment phase of the nutrition care process, we listen to the individual. So we take a nutrition-related history, we take a medical history, we look at anthropometrics, we look at biochemical data. But I think for the TCR for type 1 diabetes, what can be really missing is listening to the patient. So there are many people in the room who are living with type 1 diabetes, whether they have type 1 diabetes themselves or whether they are a caregiver for a person who has type 1 diabetes. So if you were Jordan and you were coming to approach your healthcare team and you said, they said, okay, explain to me why you want to do TCR for type 1 diabetes, what is it you would want your healthcare practitioner to know? I don't know, do we need to use mics for this? Okay. So if anyone is willing to go stand at a mic and give their answer. So you're Jordan, you have type 1 diabetes, you could be any age, you could be either, have any reason for coming. I think it's really important for the practitioners in the room to listen to the people who say, I wish my healthcare practitioner would have known this when I had come to them and asked for help.
Hi, Beth. So blood sugar roller coaster is awful, and getting off of it is important, and TCR allows that. So that's something you can add to your list.
Thank you so much, Lester.
Can you state your name and where you're from when you pose the comment? Sorry.
Okay.
Or question.
Yeah, and I think that's important, blood sugar roller coaster.
So I'm Jill Litzinger, and I'm from Missouri, and I have a type 1 son, and Beth and I are really good friends. But anyway, I would want them to know that running a patient high is not the answer. And like Lester said, the blood sugar roller coaster, it's horrific. So just so that you know, the kid feels bad, the parents are not getting any sleep. It's a really difficult situation to be in. So I would want them to know that they'll grow, they'll be fine. So that's it.
Thanks, Jill. And just on Jill's point, that's a good point. I think sometimes when you want your child to be a normal level, I think sometimes as a patient, you're looked at being like, oh, you're being a perfectionist. You're really trying, that's just not possible in type 1, or, your numbers are currently fine. And so it's really hard to feel heard when that is the answer that comes back to you. Yes.
Cynthia Myers-Morrison, and I'm a nomad. And with regard to food addiction, there are, when we do food addiction assessments, diagnoses with sugar and Yale Food Addiction Scale, so on, many people report having food addiction at 4 or 5 years old, at the first time that they can remember things. So that's something that needs to be included in.
Okay, thank you. That's great.
Hi, my name is Roxana Zodeber. I have a type 1 son, and he was diagnosed at 8. He's now 21. I cannot get him to eat this way. He says, I can't eat the foods I want to eat, so this is a concern of his. What do I do with the foods I want to eat? What do I do when I go out with friends?
Okay, so that's what you would want.
That's what I would want to know.
From the practitioner?
Yes.
Okay, wonderful. And I can answer that question later in the thing about that actual specific scenario if you'd like. Yeah.
Hi, Beth.
Hi,
Corey Cedar. Kind of a loaded question, but it ties into the two previous. I'm not there anymore. I'm a type 1 myself, but one of my initial concerns, probably because I had food addictions and everything else, will I be able to eat sweet foods, ice cream, cookies, and things like that, so that I don't feel different from other children or stuff like that? And I think you know my answer, but.
Okay. Thanks, Corey. That's great. So these are some questions that people with type 1 diabetes might come, and I think this is one of the key reasons that we need to listen, because people are actually coming to us for various reasons, and they might be coming to us because they have the first signs of complications and they want to do something about it. They might be coming to this because their child keeps having to stop in the middle of soccer practice. There could be various reasons, so we really need to understand why they're doing what they're doing. So when we listen to the patient, we're looking for what their personal goals are, their medical and nutrition histories, what their motivation and their mindset is. Some people are like, they're right in from day one, and you just cannot believe. And the most motivated people that I have ever seen, and I can relate because I had a grandfather in the same situation, anybody who has had a member a family member who has had diabetic complications. Those are the first parents that looked to this way because they saw what they saw. I saw my grandfather's feet get cut off. So when Lachlan gets diagnosed, you don't think I'm looking for a way to stop that from happening? That's our major motivation. And other people might be coming and saying, I see my friends' results, they get great results. I don't want to eat the way they want to eat, but I want their results. How do I, so they have very different needs. The second thing I want to focus on are core competencies in type 1 diabetes management. So the one thing I think I've been most surprised at is how little general diabetes education seems to be available to people these days. And I'm hearing it from various countries. In Canada, we have the Canadian public health care system, but you make these assumptions that the Americans, you have to pay for it, but they have amazing health care. And I'm even hearing people that say, no, I've had to wait a very long time to see anybody or to get into an endocrinology office. And I really think that we need more diabetes educators just to explain, how to monitor glucose or how to use insulin and how to track your inputs. So if when you're doing a nutrition assessment as a dietitian or a nutritionist and you see that some of these core competencies are missing, we need to refer these people back to diabetes care to make sure that they're comfortable in understanding that, as well as helping, work with them on the TCR. Finally, obviously, you'll check the typical things that you would check in any nutrition assessment, medications and supplements, particularly because you're going to have to work closely with the prescribing healthcare worker who is actually prescribing those medications. Biochemical data is a bit of a hard one. There are no guidelines on this. So typically in the nutrition assessment, we may look at certain labs that we want to have. You can use existing medical laboratory data that you have, and I've listed up the labs that you would want to be able to see. And you may want to do some baseline labs for certain vitamins and minerals. Some people in hospital care will say, of course we're going to do this, and other people will say, there's no way the patient will pay for this, or there's no way I will be approved to have these types of labs. So it is difficult. One thing you can do is if the lab tests are prohibitively costly for a patient, you could do a food diary of their existing way of eating. You could see if there are clear micronutrient deficiencies, and you could see if you could test for those specifically to see if there could be insufficiencies in those areas. And then we would look at supplementation and retesting at a later date. And obviously you have anthropometrics and NFPE. So that's nutrition assessment. On the nutrition intervention side, I have tried to create this so that it's really TCR specific. I think a lot of people get confused as to how we're going to be able to do this, but we can really individualize nutrition therapy within the TCR approach. And it's something that I've learned a lot about over the past couple of years, one day working with people that have been diagnosed with cancer and then also working with people with type 1 diabetes. They're actually eating quite different things, but they're all under the umbrella of TCR because they actually have different needs. So recommended intakes for energy and calorie and all nutrient needs, that obviously falls to the dietitian and the nutritionist, so they need to make sure that they have that. And the big thing is meeting hydration and electrolyte needs. And it's very important that you understand as a dietitian how those needs may change on therapeutic carbohydrate reduction. So especially the need for sodium, we tend to be wanting to have everything low fat, and we tend to want to have everything low sodium. And as we know in the room, when we are people who are used to TCR, we have to make sure that that is built into their TCR plan. The other thing that can be really helpful is that the individual could choose to go all in 100%, or if they feel that it's a lot, they could choose to have a phased in, start slowly approach. Okay. And so we actually look at, phased in, they could just start, for example, say, I'm going to just start with breakfast. I'm going to replace breakfast and get those going that way. Or maybe I want to do a low-carb weekend and I want to trial that. The challenge that we have is that we have an insulin dosing plan that must accompany this way of eating. And so we have to make sure that that's dialed in before we would phase any of this in. So my time is running out, so I'm going to actually go through and just get to my insulin plan section, because this is actually one of the most important parts. You need to make sure that you're working collaboratively with the patient's healthcare provider responsible for this, and to actually figure out how an insulin dosing plan can be created before any dietary changes are made. We often have to significantly reduce rapid-acting mealtime insulin, and some people may not need any at all. And so we want to ensure that we don't have severe hypoglycemic episodes from starting on this way of eating. And we may also even need to change types of insulin or timing of dosing. So it's very important that, that your patients are actually aware of this, and this is one of your biggest roles. And I'm looking forward to Dr. Leonard's talk on insulin that she will be giving shortly. So finally, I want to say that this is a possibility for people with type 1 diabetes, and there are thousands of people already doing it. I would like to take them out of the shadows and be able to tell their stories and share so that other people have the opportunity to learn from this and to be able to do this. This is one family who, literally this was one weekend and then a following day with 2 meals of breakfast and lunch. So finally, just patient resources. I'm not going to go through them all. I have things that I think you'll find helpful. I'm also, and to the lady who mentioned food addiction, I'm sorry, I'm not sure where you went. Oh, thank you. I'm working on a guide for RDs with 2 of my dietetics colleagues, Amy Rush and Francisca Spritzler, and we are putting these types of things together. So if you see gaps, please let us know, because we are creating this for the first time as well. But there are food lists that you can find. I do up a bunch of options for lunches, and then you can refer people to certain recipe sites, etc. So all of these things are included in the package as well. So I don't know how much time we have left. Have I talked too long? Okay. Okay.
We have time for a couple questions.
Do you want me to do these first?
Yeah,
Done?
sure.
Roxanne, sorry, I'm just going to squeeze in an online one because we were just waiting for you to come up. Thanks, Beth, so much for your excellent presentation. I have 2 online questions from the same person. In type 1, even though pancreatic beta cells no longer produce insulin, are the other pancreatic hormones and enzymes still working, such as pancreatic digestive enzymes?
Yeah, so there can be challenges there because the pancreas actually shrinks. So you will actually sometimes see people with exocrine pancreatic insufficiency, which can be something where they don't have the same capacity to secrete digestive enzymes into the small intestine in order to be able to break down the food that they are eating. Even if you just think about how come you can't have injected insulin act the same way as the body? I mean, just look where the pancreas is located. It's located right beside the digestive system, where it needs to be, so that it can actually take care of all the food that we eat, right? It helps digest it, and it helps the fuel to be utilized. So yes, there can be an issue with that.
Thank you. I have one more quick question about berberine and grass-fed pancreas. Arna knows it's beneficial in type 2 for some people, or has heard. Could it possibly be beneficial in type 1?
Yeah, I don't like to answer questions like that, to be honest. I think I could be misleading people. I really think that you need a practitioner to follow you and to work with them on whether or not that supplement would be relevant for you in your particular case.
Appreciate it. Maybe we'll bring it up with one of the physicians later. Thank you.
Thank you.
Hi. So again, about my son, he's 20-some, and he believes he needs carbs, or he'll die. Is there a magic word, a magic sentence where I can tell him, try paleo, try keto, try to restrict carbs, try something like that? It breaks my heart to see him like that.
Yeah.
And to see his future.
Yeah, I know it can be really challenging. I think oftentimes we try to get to, where is he coming from? What is he wanting to focus on? Why does he find it so difficult? It's very challenging when you're the parent trying to do that. So trying to find a practitioner that will work with him on that, so that you're slightly removed on that, can be one thing to try to get to. How are you going to meet your health goals? On the other side, if it feels like the food is too hard, the first thing I do is I take out a list of the foods and I say, circle all the ones you already eat, or that you already like, or that you're willing to try. And let's start there. And let's maybe start slowly. Would you consider, what if we just did breakfast for a week? And I made you breakfast. Here's a list of things that are low carb. Could we possibly introduce those things? And we're just going to take small steps. You know, you may have to, who knows, I mean, there are many things that I've seen. There's, you know, besides guilt trips, there's bribery, there's everything else. But will you do this and implement it? You know what I mean? So we can talk offline later too.
Okay, awesome. Thanks.
Thank you.
Allison Smart from Salt Lake City, Utah. So you touched on this briefly, but just one more. If I have a 15-year-old daughter with type 1, if someone says to me, she won't grow if she eats this way, how can I respond?
Thank you. Thank you for bringing that up. This is one of the greatest concerns, and it's actually a concern of mine. I don't see it often, but I do see, and when you actually work with people, usually the children aren't eating enough. So the first question we ask is, how many times a day does your child say they're hungry? And usually when I see a low intake of food, they say, oh, my child's always hungry, always hungry, always hungry. And it's usually not a TCR thing. It is okay, tell me why, tell me what's happening in the day. So many children are not eating breakfast. They're just not. It's a rush. So then you're not actually working necessarily on changing things related to TCR. You're building in time for breakfast, and you're switching up the family's morning so that the child is able to have at least 30% of their energy needs met at that meal. The other thing that we then do, and this is where you can use the type 1 diabetes card in schools, because often the children at school, they're not given enough time to eat. So the children aren't eating enough food during the day, and particularly when they're in growth phases, we need to build more time. So I say to families, like, go to the teacher and say, can we add in another time for snack? Can we do something to increase the energy intake of this child? Finally, one last point is, one thing I do find, and might be really helpful for prescribing physicians. A lot of parents say, I just fed them and they're hungry 2 hours later. I have to wait until the rapid-acting insulin is done before I can feed them again. And this is why the children aren't taking in as much food, because there's fear that they're going to stack insulin. Okay, so we need to be able to teach them how the child can eat when the child is hungry and not just have it be around the time action profile of the insulin they've just been injected with. Okay, thank you.
Thank you so much. Thank you so much. Another round of applause.
Thank you.
So many interesting tidbits there. The point on the ketogenic diet and the 3-to-1 ratio versus the more modern sort of ketogenic diet was such a great point. And that roller coaster, we look at those charts of the blood sugars, and sometimes we forget that it's a person's life that's getting stabilized, not just their blood sugar, it's their family's lives. So just what an amazing talk. Thank you so much.